the hour, and we see we already have projections from our speaker of the evening. I just want to welcome each and every person. Feel highly recognized, feel highly welcome to this evening's webinar. So far, we have 42 people in attendance, and we do not want to wait further. So we just want to start off the webinar this evening. And as was circulated earlier, our webinar today is on mental health in palliative care. And I'd like to introduce myself. My name is Rosalie Nomolo, serving as the Director of Programs at the Kenya Hospices and Palliative Care Association. And we would have wanted to know everyone in here, but then it would not be possible. So we request that you write your name in the chat. You can write your name and where you are joining us from, and probably what you'd want to take home after this webinar. So feel highly welcomed. We hope that other people will join us on the way as we proceed so that we save time. And that said, I just want to remind us what the World Health Organization defines mental health as. And if you'd remember, or if someone is new to the health space, then you'd remember that mental health is the state of mental well-being that enables people to cope with life stressors, whatever they be. Mental health, good mental health also helps people to realize their life's abilities and makes them learn well, and also finally helps them to contribute to the community. And these are very important aspects. Finally, I would like to introduce you to the guest to us today. As we see on the projection or on the PowerPoint presentation that is projected, we have Dr. Wanjiku Waweru. Dr. Wanjiku is a psychiatrist from the Division of Mental Health at the Ministry of Health. She's dedicated to serving people in the space of mental health. She studied at the University of Nairobi, and she holds an MMed, that is Master of Medicine in Psychiatry. She works at the Ministry as the focal person for mental health access and integration of mental health into other fields at the Division of Mental Health, as I've mentioned. And she has a deep passion for mental health. And she's committed to improving access to mental health care services and fostering the integration of mental health considerations into various sectors. I think much can be said about the good doctor who's just about to talk to us. But for now, we'd want to leave you with that so that as she speaks more, we will know more about her. So stay tuned. You can prepare your notebooks and be free to ask questions when time will allow. We'll request you that if you have a question, you'll put up your hand or you'll write it in the chat box, and that will be responded to in due time. So without any further ado, I would like to welcome Dr. Wanjiku Waweru to start us off. Thank you so much, and karibu.
I can go. Okay, sorry. Thank you so much for that wonderful introduction. And allow me to start off with the presentation. And as you've been told, I'm Dr. Wanjiku Waweru, and very honored to actually take you through on a presentation on mental health in palliative care. I'm audible, right? Hello?
Yes, you are, Doc. Yes, you are.
Okay. All right. Thank you so much for actually taking us through what is mental health. Yes, mental health is a state of well-being where individuals recognize and realize their abilities, are able to cope with the normal stresses of life, work productively and fruitfully, and can make contributions to their communities. So a positive mental health includes your emotion, cognition, and social functioning. So how you're able to think, feel, and act in that state can really affect a lot. So, and mental health is a very key determinant of our overall health and socioeconomic development. It influences how we are able to interact with others and can also better our physical health. And it shows that it can also improve our recovery from illnesses. With that, today we're going to talk about all that have defined mental health care, but now in palliative care. And as we all know, in palliative care, it's that approach where we aimed at the medical care, where you're aimed at optimizing the quality of life and reducing any uncomfortabilities that may come with the terminal illness. So as you can see, these are the principles that I was able to see, which are still in the medical care. They're the same approach that you are going to see. We are going to use when you're talking about mental health in palliative care. It's a patient-centered care. We're still going to use the holistic approach, and our aim is to improve the quality of life. And of course, in our journey, we need to involve the caregivers and also the community. And it's a team that is involved in ensuring that we're integrating this mental health care in the palliative. So, as you have said, mental health is very critical, and it's going to address the psychological, the emotional needs of the patient. And there are some mental health conditions that are quite common among patients who are receiving palliative care, and that is anxiety, depression, and that we are not limited to just this, because we also have adjustment disorder, and we can have eating disorders. But the most important thing is to know is this condition can they were existing, so before you got the physical illness, or they can develop as a response to the illness itself. So it's good to have that in mind. So that's why it's very important to ensure that we care for the patients. So as you have said, we are going to use a multifaceted approach in addressing the psychological, the emotional, social, and spiritual needs of the patients. And in doing that, we're going to provide a supportive network and also resources that are going to help this patient be able to address the emotional challenges that they arise from the time they are diagnosed and as they are receiving the treatment. Because our aim, as we have said before, is to improve the quality of life. As we have seen, mental health is a key determinant of the overall health, and it's going to really have a very great impact, not only to ourselves, but also the people around us and also our health. So it's quite cognizant that we also pay attention to our mental health, because there's no health without mental health. So some of the strategies we could be already addressing and we did not know, and that can be used to integrate mental health into palliative care, is the collaborative care model, which we're going to definitely discuss, and also definitely offering the management itself, which can be through psychotherapy and pharmacotherapy, and also remember teamwork. And it's not just one person, or it's a team that handles the patient. So we'll start with the holistic approach. The aim of this approach is to address the person as a whole. You don't see the person as with the symptoms, the pain, the fatigue, the what. Rather, you approach them in all their well-being. You look in the whole aspect, the physical, the emotional, the social, and the spiritual well-being, and how these domains are connected to each other. Because with that, you're able to see the impact the mental health will have on the health, on the person, and also what impacts the physical situation or the spiritual situation that can impact on the mental health. All that will have an overall effect on the quality of life. Still on the holistic approach, it's good to know that there are we don't have one size fits all interventions. And as we know, we are all unique individuals. So there are things that we can besides pharmacological approaches, as you've seen, we can have interventions that not only address the mental health aspect, but also the physical aspect. So they're able to help. As you can know, the massage therapy has been shown to have such effects. The relaxation techniques where people can even be able to meditate. People can even take walks. They can have squeeze balls, music therapy, art therapy, aromatherapy. All those are some of the interventions that have been used, not only to address the emotional aspect, but also the physical aspect. As you have said, the patient is viewed as a whole, not just on the physical symptom, the symptoms they have come with, but you just need to view the patient as a whole, their social life, their spiritual, the psychological, emotional well-being, and their physical well-being. So that way you're able to address, and by addressing it, you're not only tackling one problem, but it will have an impact on all the areas of the patient's life. We talked about collaborative care models, and in this collaborative care model is where you're treating the mental illness or the mental health condition the patient may be going through by integrating the physical health care and psychological treatment in one setup. This will help it will help address the wide gap in mental health treatment attributed to the short professionals. We all know that the mental health specialists are few in the country, but that doesn't mean that the patients are not to receive the care they require. So when a patient comes in and is able to meet a team, not only the palliative care team together with the team mental health care team, when they work together, the patient is able to have their needs met in one setting. They don't have to move from here and you're told you have to go and see daktari. From what you have been able to see, they're able to say that they're able to move from point A to B to be able to be reviewed, assessed, and or reviewed or do follow-up in another setting. If it's in one setting, it will really help in follow-up, and it will also help the team that is working together to be able to work together. The referrals are timely. There's timely early diagnosis of certain conditions, especially if a patient is able to suffer from the mental health conditions. We're able to realize it early and they're able to get the treatment early, which we have seen if we're able to treat the issues that are the emotional, the psychological issues that are affecting the patient, will be in a position to improve their mental well-being, which has an impact on the quality of life. And as you can see here, when you're talking about the collaborative approach, we have said the patient is able to receive all their needs in one setting. This image is of a puzzle of the brain, and you can see four like health professionals working together to be able to fix this puzzle. The same way is an approach that we are supposed to use in our setup, where we are supposed to work together. The palliative care team, together with the mental health specialist, are supposed to work together to be able to cater for the needs of the patient that is under their care. Together, they are going to be able to give the patients the best care. And in doing that, the patient is able to have a quality life and have a positive mental health outcome that will have an impact in their everyday life. As we have said, it's quite cognizant that people work together. We have agreed that for the patients to be able to get that good care, we have an interdisciplinary team. We have the palliative care team, and we should also have the mental health care team that works together. When they work together, they're able to provide their specialized assessment, treatment, and support in one setting and in a better way. So for us to be able to have this interdisciplinary team, we need to talk about mental health. We all know that when it comes to mental health, we've really treated this matter. We've put it in the shelves for a while, and it's because with the stigma that is associated when we're discussing about mental health. but we are trying to create the awareness and we are talking about it. So by doing that, we need to change the attitudes of not only the people that are around us, but also of our health workers. They need to know about the mental health because they're the same ones that are treating the patients. So if you don't know about mental health, they're not going to be able to recognize when a patient is actually exhibiting symptoms of ill mental health. So if you're unable to know, if they are aware and they are taught and also themselves are able to discuss about it, it's going to change the attitudes of the patients themselves, their caregivers, and also the healthcare workers themselves. So with that, we're going to increase interest and the training opportunities, and we'll have more people wanting to work together. And in that also to specialize. As we said, we have a shortage. But with that, it will facilitate the integration because people know and it's easier for people to work together. So in setups, we advocate for people to train or have mentorship programs that are able to provide the mental health care. That way, they're able to be taught how can you easily recognize those mental health symptoms, signs and symptoms of mental health conditions. As we said before, we have a shortage of specialized personnel. So what is there? We have guidelines that have been able to bridge the gap of how a healthcare worker can be able, who are not specialists, can be able to use those guidelines to be able to know, is this patient suffering from any mental health condition and how can I intervene? And you can even be in a position to easily refer. In our setups, we have community health promoters who are also taught how to recognize and refer. But within our hospital, we are encouraging that they use the guidelines if they don't have the mental health specialist. So that way, the palliative care providers can be in a position to cater for the mental health needs of the patients. And some of the common conditions that have been realized to be there, it is depression, anxiety, so as we also said, adjustment disorder. And as we said, you can still have a patient who has a pre-existing mental health conditions developing terminal illness, and they also require palliative care. So you see, if you have a patient who had pre-existing, this is a patient who's already on medication. So it is well if if our health workers are trained and they are aware of how to continue the treatment, if at all the patient, within the setting where the patient is going, they don't have a mental health specialist. And this guideline is readily available in the website. It's MOH document. There's also telemedicine whereby mental health specialists can work together with the palliative care team, where they're able to still cover the needs of the patient, mental health needs of the patient, because as we said, there's a shortage. That shortage doesn't mean that this patient is not going to be managed by an interdisciplinary team, because with the technology that has come, we can use we can use online platforms where psychiatrists can be in a position to view the patient on the other side together with either the palliative nurse, the palliative doctor, or physician who's attending to the patient. So the interdisciplinary teams is quite cognizant. Whether they are there within the settings, we can still have that team even with the newer technology. The other approach that is quite important when integrating mental health in palliative care is involving the caregivers and the community. We all know that there's that high burden of being a caregiver. And the caregivers, with the terminal illness, the patient is sick, but also the illness has an effect on the family members and the primary caregivers. So it's crucial that we support the caregivers so that they can be in a position to help us cater for the needs of the patients. So we are going, by integrating mental health in the palliative care, we need to talk about mental health with the caregivers so that we can have a topic that they're able to know about what is mental health and what impact it has on them, on their patients, and how can they offer support, and also how then they are able to be supported. Because by talking that, by having such conversation, they're able to know that as we take care of the patients, we're also going to take care of them, and the help is within the hospitals. So by providing that safe space, we're able to help them to come and access the services that we have within the hospitals. Of course, within our setup, we can also provide support groups. We can have rooms where we offer counseling for the ones that we have talked to and they're willing to have counseling. And that way, we'll be in a position to be able to help ease the burden of the caregiver and improve their mental well-being as well as that for the patient. When it comes to the interdisciplinary team, allow me to go back. We have said here we'll train them. For the ones who are not trained, and they are also they are in a position in the setups, they don't have a mental health specialist within their setup. We have ways of actually being able to assess. Using the guidelines, we have given instruction of how they can be able to assess them, and after assessment, how they can be able to intervene. So in that way, when they'll be in a position to say if they suspect the patient is having symptoms of depression, we have provided within the guidelines how can they assess and see how this patient is. How is the patient suffering from mental health conditions? Because you can suspect, for example, for depression, there are symptoms. The patient will come. I can feel I normally anxious. Not even anxious, I'm not getting sleep. A patient is going to come and complain of sleep. They're not eating well. They are not, they no longer enjoy doing things that they used to enjoy before. They are feeling sad and empty. They are angry. They're going to just a report of things that they used to be okay, but right now they have realized that they are not able to either sleep well, get sleep, or they're sleeping too much. I'm invited to places and I'm not able to go, and I'm just feeling empty and I don't think I'm worth of life. So you see, those symptoms can tell you this person is suffering from a psychological problem. But how can I be able to assess? So in the guidelines we have given, there's a criteria that has been provided for the healthcare workers to be able to see, does this patient fit that criteria? And in that criteria, we're able to give a timeline. Within the 2 weeks, how are you feeling? Within the 2 weeks, how can you tell us about your sleep, eating, your angry outburst, guilt? Have you had instances where you would want to end your life? We have provided that criteria because there's a criteria we use, and with that criteria, you're able to diagnose a patient. And after the diagnosis, we're provided an instance where you're able to manage. Yeah. All right. And as we're talking about also the approaches on the caregivers and the community, remember we also have to use the structures that are within the patient setting. Remember, these patients, even despite their illness, they used to go to church. They have a family set up, maybe the extended family and everything. So we still use the community, the already set up community structures. They used to go to church. They can still be allowed to go to church, and we can teach the caregivers on how to still allow them to attend or go to the structures they used. For a woman, maybe she used to go for the fellowship. We can't, just because they're facing through any psychological distress doesn't mean that they're no longer going to be able to do that. We can support them by involving even the religious leaders, which we are already doing. We're involving the religious leaders by talking to them about mental health and how they can help us deal with the stigma that is out there. So in doing that, we are still trying to see how mental health can be supported in the setup of the community, which in essence is going to help us when you're trying to manage our patients. Because When they come, they're getting the services within the hospital or within the setup that we have. But when they go back, they're going back to the community. So it's quite well that we also involve other members, even the spiritual leaders who are in the community. And as I said, we also train the community health promoters to be able to help our patients once they are in the community, like for the sake of follow-up, to remind them to go for the visits within the hospital for follow-ups, and also when they realize that they are able to see that a patient is going through a distress, how can they refer the patient? So those are other ways that we're using to integrate mental health. This is just showing how the caregiver, patient, the palliative care team, and the mental health team can work together to really help to meet the patient's needs. So if they work together, the patient doesn't have to really move from one place to the next. They can get the care that they need within the settings that they are in. So it's very convenient for the patient and also for follow-up, and it has a better outcome. So in essence, what I'm trying to put is, just as we are discussing before, and just as this picture shows, when it comes to mental health in any setup and in any area, be it in, like in our setups, we're talking about palliative care. Let's see the patient. When the patient comes to us, let's not view the patient with the symptoms that coming with, but holistically. What is their physical, social, and spiritual aspect? When we cater for any of these domains, because they really affect each other, we'll be meeting the needs of the patient. And to do that, we need to work together. There's a team that needs to work together. That team is comprised of the palliative care team together with the mental health specialist. So they need to work together. When they work together, the patient they're going to meet the physical needs and also the emotional needs of the patient. In setup where we do not have the mental health specialist, that does not mean the patient's mental health needs are not going to be met. They're still going to be met. Why? Because we have other ways we can do that. We have guidelines that are supporting our healthcare workers in setup where we don't have mental health specialists. So they can use the guidelines to be able to assess the patients and also to offer help. And I've said in those guidelines, we have criteria that enables us to assess the patient. And there are also guidelines of the medication to use. So that means the mental health status of the patient will still be met, whether there is a mental health specialist or not. Then it's upon each and every person for us to be able to talk about mental health, because one of the greatest barriers that we have is stigma. So when we talk about it, we are reducing the stigma, and we are going to encourage people to access the mental health services that are offered in our setup. Another thing is, remember, we need to be inclusive of the community and the caregivers, because they're the ones that are taking care of our patients, and there's that burden of caregiving. Of course, it might be a daughter taking care of the mother. It might be a mother taking care of the daughter. That doesn't mean they will not have that physical or emotional burden in relation to their caregiving. So we also need to offer that care for that patient, so that for that caregiver, who will in essence help us improve the mental well-being of the patient they're taking care of. And by that doing, we are going to improve the mental well-being of everyone, and the patient is going to improve their quality of life, even despite their terminal illness. The other approach that we should know is the communication. We can have a team, but they're not communicating. So within that setup, if it's the file of a patient, documentation, the communication within the different disciplines really helps. If everyone is doing their part and they're documenting, when the other, when a nurse documents, a doctor documents, a psychiatrist documents, all of them are able to work together and come up with the same plan, that they'll work together and they will handle the patient's need as need be, because they will be in unison in what they are doing. And let's not shy away from also training, encouraging people to actually go and train and study to become either a psychologist and a psychiatrist. In mental health, we have a team. That team will have a psychiatrist. A psychiatrist is able to prescribe medication and is able to also offer other psychotherapy, but mostly the psychiatric clinical officer, psychiatric nurse, and a psychiatrist are authorized by the association to be able to prescribe. We have the psychologists who are able to take through our patients. They have, most of the time, they use the behavioral therapies, the various therapies that they are there to be able to help the patient navigate what mental health distress that they are going through. We also have the occupational therapists, we talked about them, and we have the social workers. All of these disciplines are involved in ensuring that the mental health needs of our patients are catered for. So even if you forget anything we have talked about today, don't forget that we have said mental health is a key determinant of overall health. So there's no health without mental health. And for a patient in any discipline that we're in, we need to work together and we need to be able to ensure that the patient, not only we cater for the physical aspect of the patient, but we're also catering for the other aspect of the patient, the emotional and social and the spiritual well-being. Yes. Questions now, I can take questions.
Thank you so much, Dr. Wanjiku. I think the presentation has been short and sweet, and we yearn to hear more. So far, I'm not seeing any questions from the chat box. I would encourage those who would want to write their questions to write them at the chat box. But then so far, we see hands up already. So we would give this chance. We'll take a round of 5 questions if we'll have if we'll have 5, and then after that we'll defer them to Dr. Wanjiku to answer. Then we'll take another round. So I see first up Dr. Ali's hand is up. Dr. Ali, you can unmute your microphone and ask the question. Dr. Ali?
As we wait for the question.
Yes, Doc.
As we wait for the question, it's important for me to actually just put it there. Like I just mentioned some of the common mental health conditions that patients in our palliative care can suffer from. And it is anxiety, depression, can have adjustment disorder, but that doesn't mean that we are not going to get other conditions such as schizophrenia. But I did not want to talk about the symptoms because also the symptoms, for you, when we are assessing the symptoms, we have a criteria and we can only suspect. And one of the ways that you can know that you're suffering from a mental health condition is you're not able, you remember we talked about how we act, think, and feel. And our mental health not only affects us, but the society. So first of all, how you eat may be affected. You may find yourself you're eating more than usual, or you can not, poor appetite. You can find yourself that getting sleep is a problem, or also you're sleeping a lot. You're no longer interested in the things that used to interest you. You don't want to associate with people. You want to alienate yourself. You're feeling sad. You're hearing voices, or seeing things, or you can even feel the sensation, what you call hallucinations, or you can be delusional. So all those are some of the symptoms or the signs when someone is having mental conditions, and everyone is at risk because, as we said, in life you have up and down, and there are things in life that can trigger us into suffering from mental health conditions. Loss, you can have loss. A loss can actually predispose you to suffering from a mental health condition. Also, being diagnosed with a terminal illness, because sometimes an illness requires you to adjust, to make adjustments in your life, something that you had not planned. So in life, there are those predisposing factors, there are risk factors, and you can have a mental health condition because of your physical condition, and a physical condition can make you suffer from a mental health condition. And as I said, there's no health without mental health. Any discipline in health can predispose you to mental health. So and that's why it's very cognizant for us to try and offer these services within our setups. Because as a caregiver, as a doctor also, you can suffer from a mental health condition. So you need to see that with our workplaces, are we ensuring that we are working in good workplaces? Are we indulging in self-care so that we don't suffer from burnout? Because we all know sometimes, as we've said, we have a shortage. We can be the candidates who suffer from the mental health. So the mental health services within the palliative care are not only for the patients and the caregivers, but are also for the providers, because if you said anyone can suffer from a mental health condition. I can take questions now.
Thank you so much, Dr. I think she's gone ahead to describe some of the conditions that we may find in patients with palliative care needs and the symptoms and probable management. So at this juncture, she's open to questions, and I've encouraged us to share our questions or our comments in the chat box. And while we work on that, we are also open to taking questions that are live. So perchance you have a question, feel free to raise your hand using the raised hand icon, and we'll make it easy for you to speak. Thank you. Don't have questions, you can give comments, or we can talk about cases that we've seen before at our areas of practice. Probably maybe seek, you may probably seek Dr. Wanjiko's wisdom, maybe how best that patient or that family would have been handled. So let's feel free. Okay, throw the questions.
Can I
Okay,
address
I
the
can
questions?
see. Yes. Sorry, there are questions here. I see some questions have now come in. Yes. There's a question from Jacob Kiplangat, and he asks, as a psychiatrist, do you have any role in palliative social injustice? I'm going to read that again. First question is, as a psychiatrist, do you have any role in palliative social injustice? Then Lilian Awor is commending you for a great presentation, and I concur. Thank you. Then we have Mr. Ngugi. Just a second. Yes. There's Gilbert Kipkemboi, who asks, what are the best practices and challenges integrating mental health care into palliative care services for cancer patients, especially in low-resource settings, which are the predominant ones in our healthcare setups? And there's a question from Colin Sotieno, who wants to know how aromatherapy helps in pain management. And there's Dan, who asks, what if a psychiatrist, I think he meant psychiatric patient, declines to take medication? I think those are 5. So I'm going to, Dr. I'm going to request you to respond to them. Yes, there's I hope I captured all of them for now, the 5, and then we'll continue having more as we proceed. Thank you.
Okay. On the question about what if a psychiatric patient declines to take medication, is what happens is when you're having a psychiatric condition, depending on the one that you have, for example, schizophrenia, your decision making is impaired. And in such instances, in our Mental Health Act, Amendment Act 2022, we have defined, the law has defined who can decide for you, because in some instances, they're declining medication because they're not in the right state of mind, in that they cannot be able to make a decision. So in that care, there's a supporter. We call them a supporter who had been appointed by the patient to make the decision, so they can give the consent to the doctor who can offer medication to the patient. Because at times you'll find that in certain mental health condition, a patient can be in a position to harm themselves and don't want to harm themselves. So we can use medication either to calm them if they are violent, and if they are having, they can cause harm due to the symptoms there. For example, hallucination or the voices that they are hearing. You need to intervene for the safety of the patient and also the people around them. So in that, the law has catered for that, whereby a patient can be a consent, how the consent can be given in such a case, so that the patient can be given medication. In some instances, you can get a patient who just refuses and would like to use alternative forms. We have had instances whereby if you are not able to administer medication to a violent patient, there are techniques that you use to de-escalate the matter, to try and calm the patient, and also to try and explain to them why you need to, what they might be they might be exhibiting in terms of symptoms. For example, if you're talking about depression, where a patient says, I don't want anything because of course, so maybe their culture or belief, so you're able to offer psychotherapy as you're able to explain to the patient, so that you may be able to give them the appropriate management that they need. So we don't force. These days, we try and give dignified treatment to our patient. What are some of the barriers or challenges that we face when you're trying to offer mental health services for our patients in any of our setups, especially in the low income setups? I think, was that a question, Emily? I'm just hoping that's how I captured it, but
it's the question.
Yes, okay, Roslyn, thank you. We do have one of the major, we have knowledge gap, whereby people do not understand about mental health. There's a lot of myths and misconception, which really affect access to care and services. So, and accompanying that, we have a shortage of the mental health specialist. So also we would like to avail and access this care, but it's not quite available. But to cater to this, that's why we came up with a national clinical guidance, which were launched in September. And we were trying to cover this gap, but it's something, we're still doing the baby steps. So, but there's knowledge gap, and the shortage of the mental health specialists is quite huge. As for the telepsychiatry, would like to offer it in such areas, but the network connections, and not all areas within our country are privileged to get good connections. So that one can also deter us trying to access the specialized care to the people that are within those setups that there's low internet connections. Of course, also medication. We have had instances where patients require, we have we're emerging. So we have in our medication, we have first generation, we have second generation. The first generation I'm talking of, they're quite affordable, but they also have side effects. But now we have the newer generation that are relatively not cheap. They're affordable, but what is affordable to one person may not be affordable to all. And unfortunately, not all our patients can be able to get them. And the supply, some counties are not able to get some of the newer generations. So they suffer from stockouts, which we try to cater for because Kehpca has come up with, where we have updated the Kenya Essential Medication List that will try and curb this issue of medication not being in certain areas or rural setups. So everyone can be able to access the medications, but also the shortage stock out on medication has also been an issue. Stigma, discrimination has also been a very major roadblock in trying. In everything that we do, the culture, the myth and conception is the biggest challenge that we have, despite the other challenges that I've actually mentioned. The other question was, have I been able to have answered the one of psychiatric decline medication, the challenges? Roslyn, is there any question that I've not addressed? There were 5.
Yes, Doc, there was the question on, let me just refresh. Just a second.
Yes.
Yeah. Someone was asking, before we go to the next round of questions, the ones that had come in, someone was asking, what are the best practices and challenges in integrating mental health care into palliative care services? I think you answered that. There was one on how does aromatherapy helps in pain management, and I think you have responded to what if a psychiatric patient declines medication. So in the first round, the one that is remaining is the role of aromatherapy in pain management. Then we'll have Sharon ask a live question and Dr. Zipporah Ali, then we'll have the next round of 5 questions. Thank you. Back to you.
All right. Allow me to just declare that I've read on aromatherapy, but I've not been in a position to just use it or a patient. But what happens, aromatherapy helps to relieve stress and many other health issues in daily lives, where they use natural plant-based, like essential oils. You can have those nice, what can I say? See, there are people when they're taking walks, they'll like to smell a flower, or when you're going diffuser. So there's a room where they're able to use those diffusers, and they're able to guide you on how you can just inhale, exhale, because by doing that, it's helping you just feel relaxed. And by feeling relaxed, you're not going to just, when you're anxious, there are a lot of things. You even sometimes experience physical symptoms, the sweating or the palpitation, the breathing is fast. But when you're relaxed, there's a way your body just lets go. So the blood flow you're not going to feel uptight. So that's some of the ways that aromatherapy has been helped. Mostly it's on the stress and anxiety. So it has shown to really calm people down and to help them have that clarity when they're trying to figure things out. I may not be able to just say, I know they can improve the sleep quality, because when you're relaxed and you're able to, your blood flow, and you're able to breathe nicely, your body, there's that effect that you can have. You can produce endorphins that makes you just have that good feeling and not really focus on what you may be going through. Yes.
Thank you so much, Daktari.
Yes.
Yes. I think so far
The
the
only
questions that
issue
were...
with
Sorry.
The only issue with aromatherapy, I think it's individualized, because smells, just as perfumes, there's one perfume that may be good to you and it's not good for the person. And sometimes, unfortunately, you can be allergic to some of these sent. So those are some of the risks when it comes to aromatherapy. Yes.
Thank you so much, Daktari, for tackling the first round of questions. I'm going to give this chance to Dr. Ali to come up with her question. And
Okay.
then after that, Sharon, you have been unmuted, so just click on your microphone and you'll speak. Thank you. And then we'll take the next round of 5 questions. Thank you. I don't know if Dr. Zipi is still on the call. Sharon, you can ask your question. Your hand is up. Sharon, you can unmute and speak. Oh, sorry. My microphone was muted. I was saying, Sharon, you can unmute and ask your question, the live question. Looks like she can't hear me. So I'm going to take I'm going to read out the next round of 5 questions. There are many comments coming. There are many comments coming in to applaud Dr. for the good presentation. Lillian is saying, well explained, Doc. Alphonse Yegon is saying, good presentation. Then we have Alphonse Yegon and Dr. Zipporah Ali, who've written in a question asking how psychiatrists and psychologists work together. Like, how is the collaboration? Where is the line? Though Dr. had explained a bit, but seems like we need more elaboration on this. That's the first question, the collaboration and how psychiatrists and psychologists work together. The second question is how best to break the diagnosis of cancer to a patient who has a parent diagnosis of diabetes and hypertension. How to break the cancer diagnosis to a patient who has a parent diagnosis of diabetes and hypertension. That's the question. Then we have Victor Kibet, again asking this question on the barriers to providing mental health support in cancer palliative care in low resource settings. Then we have Benjamin asking, how do we differentiate between depression due to illness and normal sadness related to end of life in palliative care? And then it's a similar question that is asked by Dan. Then we have someone asking, there was a question on what are I think that has been asked again. So at what level of a condition would one give or offer palliative care? And finally, one asks, is palliative care covered by SHA? I think those are 5. Daktari, I hope you have captured them. Yes. Karibu.
All right. As I'm addressing them, in case I forget any, please do me the honors of reminding me.
I will, thank you.
Yes. I will start by addressing on the issue on the psychiatrist, psychologist. Yes, they are part of the mental health specialist, and they are, of course, their expertise is in mental health, but they definitely need to work together to prevent and also to treat. They need to carry out promotion, preventive, and treatment of the patients. And the only difference is that as I said before, a psychiatrist can prescribe medications. We have for you to become a psychiatrist, you have to have done MBCHB, that is your degree. For me to be a psychologist, I don't have to have done my degree in medicine, but we have doctors who have studied to become psychologists. So in that instance, there's a time we're discussing the MBCHB certificate allows them to be able to prescribe. But now a psychologist without medicine, degree in medicine, cannot be able to prescribe. They're not allowed to prescribe. What they do, they offer cognitive and behavioral therapies and in deeper ways. And so they're able to give those sessions. So for instance, if I'm a psychologist and a patient can approach either a counselor, a psychologist, or a psychiatrist. If they're able to, their first person of contact is a psychologist, they'll be in a position to access to do an assessment, and from the assessment they can tell this patient will likely require medication to help deal with the symptoms that they're going through. Hallucination, you can't treat hallucinations with psychotherapy. So in such instances, and delusions, in such instances, you need medication, that antipsychotics that can help deal with or you need to send them to a doctor so that they can go through intensive investigations to know why. Is it purely a psychiatric condition that is causing them to have hallucination? Is it a medical condition which if treated can be able to treat this or deal with the hallucinations? So for that instance, they all can help the patient, but the only person that is required to prescribe is a psychiatrist by law. The reason is also because of certain medications that we're using require close follow-ups. And without those close follow-ups, without that, like for example, lithium is one of the medication that we use when you're treating certain mental health condition. It has a very narrow therapeutic window. So you need someone who's able to monitor you and able to know, because that window between taking the right amount of medication and being in a position to overdose is it's quite narrow. So the psychiatrists can prescribe, a psychologist cannot prescribe, but we have doctors who are psychologists. Yes, counselors can offer. We have certain counselors they can just counsel, but they cannot offer certain therapies. And as I've said, we have cognitive therapy, we have behavioral therapies which are offered. There are certain mental health conditions that don't require you to be able to be put in medication. If you're having an adjustment disorder, if you're having some anxiety, stress, all those, the psychologist can comfortably be able to manage a patient. The psychiatrist and the psychologist need to work together, because a patient who's been given medication, for example, had sleep issues and now could not be able, through psychotherapy sessions, to be able to get sleep back, you need to put them on certain medications. So they need a psychiatrist to prescribe. So the psychiatrist can prescribe and still encourage the patient to continue attending the psychotherapy session. And after the session, the psychologist is supposed to refer the patient back so the doctor knows that the patient is doing quite well. So they need to work together to be able to give effective form of mental health care. And mental health care is not just medication. We also need patients to go for therapies and follow-ups. So that's why both the psychiatrists and psychologists need to work together. On the issue of, I remember you asked about, I think I'd addressed the issue of the challenges, but I can still repeat most of the major challenge. Yes?
Sorry, maybe we can mention again in passing, but yes, you had responded to that. Thank you.
Okay, yes, we have stigma, we have discrimination, we have shortage of medication, we have also shortage of the healthcare workers, and also we have the issue of, I think I'd mentioned like how many, I'd gone into details, but those are the major issues that we have. The other question was on, it was something about how do we integrate, or how do we break the news to a patient of terminal illness or big news. Actually, when it comes to mental health care, remember we have said we are going to cater for the needs of all. You have the patients themselves, you have the caregivers. And most of the time when we're going to the hospital, we have someone accompanying us or bringing us. The thing is, even ourselves, if someone is to come and give you news, either there's good news or bad news, the way the message is delivered really helps how you're able to internalize. So I would say we normally prefer that within the hospitals we have either counselors or psychologists who are able to now try and break the news to the patient in a language they can understand, in that you can't just tell someone you have cancer, because some of the things that we tell patients, they tell to really make them feel like it's the end of the world. No, we need to, in a dignified way, we need to communicate to the patient what we are, from the time they were giving you the symptoms, the moment they came to a doctor, and the doctor is, the minute you're seen by a doctor, the treatment starts. So as you're running your test, you may suspect. So immediately, your communication with the patient will also help them to understand where you fall at. If in your symptoms they're doing tests because you're thinking they have a mass, and this mass may be malignant or benign. If you work hand in hand with them, they'll be in a position to internalize the message. And besides that, after breaking the news, after walking that journey, and you need to tell them, from what I can see, these results are pointing at that you have a mass, and this mass shows that it is either malignant, and this is how we treat it. Just break it, provide the information, and besides that, it will be prudent for them to go through. Either if you have a counselor within the hospital, the counselor should take up to be able to talk to help this patient digest the news and to break it more, because they might also, there are instances where you'll hear some news and you will completely go blank. You can't even think. So you need to be able to train our people to, how do you look after breaking the news? How has the patient reacted? How do you think, what effect? Because some effects we can actually see from their facial expression and how they ask questions. So it's good to include them from the start. Even when you're doing the test, you can be in a position to say, this is what I'm seeing, and you can work together with the counselor that is available within your setup to be able to take the patient through the news. Because as we said, there are certain conditions that requires adjustment in life. And if no one gives you that support, no one holds your hand, they may be in a position to not really benefit from certain services that we offer within our setups. So we need to work together with our counselors and psychologists within our setup to be able to take the patient through and to be able to work with them through the journey. Yes. Have I forgotten any question?
Thank you, Dr. I think you've handled most of them. There's a question. There are questions that will defer to the Kehpca team, maybe to
Yes.
to also, respond to towards the tail end of the presentation. Kindly, there's this question that, as a psychiatrist, do you have any role in palliative social injustice? And Wilson Gugu also asks, he commends you for a good presentation, then proceeds to ask what mechanisms are put in place to sensitize other health workers to embrace mental health, especially for oncological patients. And then he says, for in many setups, majority of the cases are just assumed to be brain mets. Yes. So those are the questions that I'd like you to answer. There were questions around at what time do we start palliative care, and the role of SHA in financing palliative care, which I'll defer to the Kehpca team towards the end of the presentation. Yes. So Dr. Reed, those two questions so far. And then we have hands up. There's Wefwafo and there's Sharon. So after Dr. Reed answers those two, we'll give you a chance to give your questions. Thank you.
All right. About the psychiatrist's role in the social injustice, what I can, from my understanding, as I mentioned today, our Mental Health Act was amended in 2022, and part of the amendment was to improve the quality of care, especially for our patients, and also in a dignified way. So when you're treating this patient, we have always advocated for us to treat the patient in a dignified way, in a way that they feel they are heard, they are respected, and the law protects against that. And when you're getting trainings these days, we do something called QR rights. And the QR rights, we are able to be taught how to handle patients, as I said. How do you de-escalate without feeling that the patient is treated in a humane way, how do you help them navigate through? So for us, our role is we are able to be taught how to, I think we can, through that, through the training that we have gotten, especially through QR rights, we are able to improve the quality of care of our patients by ensuring that we are promoting the rights of people with mental health issues, not only them, but everyone. So I think we provide care in a dignified manner, and we really try our best. On how we can sensitize our workers on the mental health integration in palliative care, there are various ways we have handled this is by we do various campaigns where we, in any forum where we are able to, we try our very best to talk about mental health and talk about demystify some of the misconceptions that are there. We're able to carry out trainings. We have various documents that are there that we try to disseminate and also sometimes train. Like we have the Kenya mental health policy that advocates, one of the strategies is integration of mental health in other areas. So we really try our very best to ensure that we are talking about mental health in those forums, and we're encouraging people to actually try and talk about it so that people can be able to access and reduce the stigma that is out there. We also try like this year we want to do like we've been trying to do conference where we'll be able to bring different stakeholders who deal mental health, and everyone. Actually, it's an open conference where we invite everyone to be in a position to talk about mental health, to discuss about it. So generally what we do major to sensitize is just talking about mental health, and in various areas, be it in the family setup, be it in the community setup, be it in research where people are able to discuss of the latest technologies in terms of what is happening in the mental health space. So those are some of the ways we're able to do that. It's advocacy and awareness creation, campaigns, and also, yes. About SHA, when it comes to mental health, I said that it's not quite specific to palliative care. It's in all areas. And as you said, the palliative, like a patient with terminal illness can already be suffering from a mental health or mental health. The terminal illness can lead to mental health issues. So there's a cover mental, like you cannot be turned back because you are suffering from a mental health condition. So as long as you're suffering from a mental health condition, there's that cover that is being provided by SHA. And the law requires even the private, if anyone is denied mental health care in a facility because they're seeking the care with a private insurer, if they're denied on that grounds, the law, our Mental Health Act protects, as I said, protects the rights of our patients, and there's a fine that insurance company can be fined. So they also, these days, mental health is not being discriminated upon. It's within the care that is provided within the cover, their mental health package. Yes. I hope I
Thank
have
you, Doc.
addressed some questions. Yes.
I think the questions have been addressed. The question on the psychiatrist's role in palliative social injustice, and yes, and the other question on the barriers was addressed. Yeah, and there was this, I think I asked this, and then we give the floor to the ones who have live questions. How do you differentiate between depression due to illness and normal sadness that is related to end of life? Because at the end of life, patients have that sadness, anticipatory grief and all that. So the question is, how do we differentiate between these two? And then there was that question on how do healthcare providers take care of patients who have mental health issues and do not think that the issues they have are just maybe due to a brain metastasis. It's those two, and then we give Sharon the floor. Thank you.
Okay. Let me start with the one for like about having brain metastasis and having mental health issues, if I've gotten you correctly. As you have said, you can have mental health symptoms mental illness symptoms due to a physical condition or due to a space occupying lesions. We have different parts of the brain and they have different functions. So you have the frontal. So depending on where your is it the space occupying lesion, the tumor is, you can have some you may actually have some symptoms. You may depict some mental illness symptoms. So in that instance, you still need a psychiatrist. It's just that they'll be able to say, is it because of the illness or is it because, yes. Because, for example, if I got the tumor and from the history that my doctor was able to take is true, like they're able to tell the chronology of how my symptoms started when they discovered I'm due to my illness, I'm already having an oncological issue. And then given with time, when I have met, I'll start depicting the symptoms. As opposed to someone who already had, as we said, you can have a pre-existing mental health condition and still develop a condition. But all in all, both of these patients require care. You cannot say they're not going to get care because it's because of your condition. So all of them, they're still going through a mental health condition. So in that instance, your oncologist needs to work together with their psychiatrist so that they may be able to see what form of intervention they'll give you to be able to deal with the symptoms that the patient is presenting with. Yes. On sadness and depression, as I said before, we have a criteria that we use to be able to do the assessment. And with that criteria, it's for when I'm assessing the patient, I'll be in a position to, as I'm engaging with the patients, I'm able to use the criteria to be able to come to diagnosis. So with most of the time when you're getting patients, I can be predisposed to developing a major depressive disorder because of a situation that was not recognized early. Like due to a loss, we have complicated grief. Complicated grief is, we all grieve. Loss can be because of loss of a job, loss of a patient, loss of a family member, or also patient themselves because they know they're dying. They can also go through some form of depression because of the end of life. All in all this situation can be differentiated with you by using the DSM criteria. And besides that, you need to treat, you need to recognize the symptoms early for any of these to be able to intervene to prevent it from now worsening. Because even major depressive disorder, you have the mild, moderate, and severe. So the mild form of depression, you can be in a position to it has the same presentation as the sadness, but also the treatment is they need to, both of them, they can require to not use medication, but with good psychotherapy and counseling, you're able to help the patient navigate through what they are experiencing or to be able to help them cross over the major issues that they're psychological issues, difficulties that they're going through. With major depression, you need medication. So yes, you can be differentiated using the criteria. Everything we use the criteria because it's well depicted in the criteria. It's a big book, but sometimes it's normally we have a summarized version, but we all know that we cannot say every time you're sad that you are depressed. With depression, it's a mood disorder, and it's definitely with depression, it's going to affect how you feel, how you think and act. Like, how are you acting around people? I can feel sad, but still be able to eat, be able to meet up people, and be able to do certain things. But if this sadness is moving to in a way that it is affecting my work, it is not, I'm not able to do, I'm not able to do my daily, it's affecting my daily functioning. This one definitely you need to be treated, but to use the DSM criteria. But yes, you can be sad, which is a normal reaction and to difficulty, but when it starts affecting your normal way of life, then definitely mental health specialists needs to help you navigate through it.
Thank you so much. I think that is very clear that we can be sad But when now the sadness becomes disruptive of our daily activities, we can't even perform the activities of daily living, then now we need to see a specialist. Dorothy Atieno and Rose White are commending Daktari on the good presentation. And I can see Sharon's hand was still up, and Rose White's hand has also come up. And I don't know, Sharon, can you hear me? I don't know if she can hear us, or maybe her question has already been responded to. I see Wefefa's hand has been put down. Probably he has been responded to. So Emily, you can help me enable Rose White to speak. And as we work on that, I want to read a comment from Gilbert. Gilbert says, in the palliative care setting, we often use the spikes model as a structured approach to breaking bad news. It helps ensure that communication is patient-centered, compassionate, and supportive during what is often a highly emotional and vulnerable time. I think that has been heard. I think he's speaking to the question around breaking bad news of a cancer diagnosis to a patient who already had, is it a parent with the diagnosis of diabetes and hypertension? Yeah, so that should give guidance on that. So I see Sharon's hand is up again. Sharon, kindly unmute and ask your question. I know where the challenge is. Sharon seems not to be hearing us. Yes. Rose White, kindly go ahead and ask your question.
Okay, good evening, everyone.
Good evening, Rose.
Yes, I wanted to ask about suicidal ideations, how to navigate with it, because most of the patients that we are seeing who have palliative care issues, they come in with suicidal ideations, and at times you find even it's not the patient alone, even the caregiver is also having the suicidal ideations. And again, I can say a practical example whereby we lost a client's wife because of suicide, and she was feeling so much overwhelmed about the burden of taking care of her husband. She ended up now taking up her life. Now, after she took her life, the family is coming in with issues of inheritance, like there's a history of suicide in the family from wherever she came from. Now, right away, we are struggling with the son who is having also the same problem, because they are feeling so much overwhelmed with the care of their dad. How do you go about such a scenario? How do you address suicidal ideations, suicidal thoughts? I don't know whether it's thoughts or ideations, or I don't know how I can put it, but I hope you've understood my question.
Thanks a lot, Rose. Dr. Maybe I read a question on that. Someone is asking on the role of mental health specialists or experts or workers. You already explained the demarcation between psychologists and psychiatrists and what they do and what the others are a bit limited in doing. But there's a rider question someone asks, there's a new cadre clinical psychologist. They're not medical doctors by profession who have gone ahead to do psychology, but they're clinical psychologists. Are they allowed to prescribe alongside the question on suicidal ideations, tendencies, and thoughts? Asante.
Psychologists are not allowed to prescribe. Yes, it's psychiatrists. It's just that you see, we each cadre has a regulatory body, and there are those mandates that you're allowed to do. That's why we have licenses. And if you do something that's not within your practice, you can actually, your license can be revoked. And this is a very huge debate that has even occurred in spaces where people feel like wanataka kung'ing'ana. But the point is, psychiatrists can prescribe, psychologists no. Yes. and instances where they prescribe, they're those with the underlying, they did MBCHB. On the issue about suicidal ideation, suicidal behaviors where you can have someone who has died by suicide, and suicidal ideation and suicidal attempts is a major issue that has been there, and we have had even issued a suicidal advisory, whereby we are trying to see if we can reduce the mortality of the death by suicide by 10% by 2026. So the various ways we are trying to intervene that is, first of all, is talking about creating safe spaces where people can be able to talk about mental health. They can be able to communicate of the issues that they are suffering from or what is bothering them without without them feeling judged. So we want to create those spaces so that we can we want to ensure that the mental health services are availed, first of all, and people can access them. And the major issues I talked before is about stigma. We have had instances where families don't want to declare that a person died by suicide because of the stigma that is associated with it. But we are trying to talk about it because we can be in a position to intervene. And for people who die by suicide, most of them already had an underlying mental health condition that was not being managed. We have instances where we can be able to assess patients. And when you assess patients, it's suicidal behaviors are among the major emergencies in psychiatry. And this requires for our patients to be managed in inpatient care, because there's that guideline that we give on how we should manage patients who have suicidal behaviors, and that entails the suicidal attempts. A suicidal attempt is whereby I knowingly tried to take my life by either hanging myself, and maybe I did not die, but that's a failed attempt. So death by suicide, definitely you manage to take your life. And plans is whereby a person is feeling worthless and they're saying that they would like to take their life. So all those instances, when we managing them, we manage them as psychiatric emergencies, and the patient requires to be an inpatient, and there are ways that we manage them. In some instances, we don't have, because it could be because of an underlying medical condition. So medical condition or a mental condition. So most of the time, we advocate that it has to be inpatient. In instances whereby we have history, we normally try our very best to talk to the family. We can also do like a family therapy where we are able to establish what's the one thing that is leading this family. Because there is what we call copycat. Copycat is someone died by suicide and someone else is going also to try the same and they end up taking their life. But all in that is covered within a policy that we have. It's called suicide prevention policy that is up to, the policy runs from 2021 to 2026. And our idea is to try and reduce the mortality by 10% by, of course, advocacy, trying to talk about mental health issues so that we can create safe spaces people can access and talk about it. When they openly talk about what is bothering them, we are able to intervene and we're able to prevent deaths by suicide. Yes. And instances whereby we have patients losing their relatives and property is an issue, such a family can be able to be, they can do, if they accept and they're taught well, they should be able to be taught that there are legal ways they can approach that, or how that you can find that property is not the main issue. Within the family, they're having certain family issues that are really culminating around them, not necessarily about property, but there's that dysfunction within the family, which they can be helped through therapy to be able to solve them. So everyone is reacting or handling the situation the best way they know how. But if they have someone who's guiding them and helping them through therapy, they can be able to handle the situation differently. I hope I've addressed the issue.
Thank you so much, Doc. We have 6 minutes to the end of our presentation, and I would like to thank everyone who's stayed with us so far and for the many questions and the interactive session that we are having. We have a question from Teresa Ireri. Then someone comments that the biggest challenge in our healthcare is our healthcare workers who are not trained or choose to ignore the process of breaking or sharing sensitive news and generalizing patients. Yeah, I think we've answered most of the questions, so we'll give it to Teresa Ireri to ask her question. Then we'll summarize the presentation, and then I'll ask Kehpca's executive director to give his comments just in that rolling sequence so that we keep time. Thank you so much. Karibu, Teresa.
Thank you very much, Dr. for the presentation. Quite enlightening, and learning is taking place. Mine is not a question per se, just maybe to chime in on what Dr. said about psychologists and psychiatrists working together. Let me speak from a position or a stand of counseling psychologists and most of palliative care nurse. So basically, when we talk about prescriptions, the psychiatrists prescribe medication for patients who have psychological, psychiatric manifestations per se. But in the palliative care space, again, when we get together, very importantly, like for families, and when you're doing the support groups, then psychologists and counselors prescribe, depending on what approach you're using, they're able to prescribe whether exercises or homework, if that is going to be from a behavioral approach, if it's going to be from a cognitive behavioral therapist approach, there are going to be some prescriptions, some things to be done. So generally, like just to emphasize that the two go hand in hand and very, 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 very important, specifically for the caregivers. And actually hearing from Rose White talking about a caregiver who was overwhelmed and actually had to die by suicide, because the talk therapies are helpful very early on as you assess the patient, and also you are asking the caregivers about their caregiver difficulties or having conversations with them. Very, very important, because it helps you pick where they are at psychologically, and also recommend or support them through that journey. Yeah, so I think it's very important to just appreciate that, the role of the mental health team actually, and just not miss it as we do it in palliative care, as we are assessing the 4 domains. Once you're able to pick something, just to let the mental health team come in and see the patients or the families early enough as we continue with other care. Very, very important. Thank you.
Thank you so much, Teresa. I don't know if Dr. has something to say. Maybe we'll let her give her final comments. Then, because of time, we'll just usher in Mr. Musyoki, Kehpca's executive director. He'll comment on SHA's role on palliative care and the strides that have been made. And he'll also comment briefly. I've commented on the questions, but he'll also comment about when do we initiate palliative care? Is it the same as end-of-life care? Thank you. Dr. Karibu.
Let me be quite fast. I want to concur with what Teresa is saying, in that whatever, you remember, you can be a patient, so treat patients with empathy, understanding, and also validates people's feelings. So if they're saying they're sad, don't, and with kindness, the way you would like to be treated, please treat another patient. And it's always good to offer support, listen, and check on people, even your workmates. They can be the caregivers, because the burden of caregiving is real, and it has some emotional and physical burden. And also advocate for protective mechanism or life skills that people can incorporate, can do to be able to deal with the everyday lives. Thank you.
Asante sana. Karibu sana, Mr. David Musyoki, Kehpca's executive director.
Thank you. Thank you, Roslyn, and Dr. Wanjiko, and everyone who made this day well, successful, and at least having, closing it from the Kenyan perspective on a great note, despite the activities and the sad aspects of the day. And we happy that at least we're talking about mental health and good information shared. So thanks. Just a quick comment around SHA and support for palliative care. We are happy that the recent developments are that patients under inpatient support at least get comprehensive palliative care support. But we realize there is still a huge gap in terms of most of the patients who are requiring palliative care and are in home setups or are seeking outpatient kind of support or services. And it's something that we all need to continue to advocate for, even as we develop documents that would guide that process. SHA says it would take a progressive realization or support, but that is a step that we'll need to all cross as we continue to do advocacy. Just to close, because our time is up, before we close, I wanted to make an announcement that we have we're planning for our big conference, the 7th National Palliative Care Conference. It will be hosted in Mombasa County. We will be communicating the venue very soon in a few weeks. And therefore, I'm encouraging everyone to prepare. It would also be a good opportunity to take care of our mental health, care for the carer aspects, because Mombasa is a tourist kind of a center, even as we share best practices matter as palliative care. That said, let me wish everyone a good night or a good morning for those who are in different time zones, and may we continue to, advocate for palliative care and support patients as well as families who need this kind of support. So thank you, team, Kehpca and Dr. Wanjiko and everybody for coming and being part of this. Bye and good night.
Thank you so much, David. To our esteemed colleagues who joined in, thank you so much. Just in case we forget everything that Dr. has said, the call to action today was let us see the patient and not the symptoms that they present with. Let us encourage people, especially healthcare workers, to be mental health specialists or to go into mental health fields. And then we all work together, much as there are few areas where, that are preserved to some professionals because of level of training and monitoring of, drugs and toxicities and all that. So with all that, remember, for you to care for others, you have to take care of yourself first. You cannot pour from an empty cup. Have a good night. Thank you so much for attending.